Hi all, welcome back. From today onwards, we are going to start a new type of discussion, case-based discussion. This is the most important for emergency physicians. As soon as you see a case, you need to decide which system is involved and you need to be very fast in registrating the patient. So case-based discussions are going to help you in your clinical practice and also for your exams. So I'm Dr. S. Prakash Babu, Associate Professor of Emergency Medicine at Karpag Vinayagar Institute of Medical Sciences and Research Center, Changalpattu. So let's get on with the case. First, I'm going to present the case with a 60-year-old male patient who has presented to emergency department with a 2-week history of worsening of breathlessness with a non-specific chest discomfort which is of recent onset and feeling his heart is racing even at rest. Previously, he is able to walk everywhere, but now he gets breathless even in daily activities. His past medical history is notable for hypertension, for which he is an amlodipine and hydrochlorothiazide. As you all know, this is a ASCII type of question. This can be given as a scenario where you need to diagnose during the exam, you need to diagnose and you need to manage. And if the patient presents, what history you need to take. The most basic questions here include so what is the patient presenting with and how are you going to deal with the patient, starting from primary assessment and stabilization of the patient and final diagnosis and specific management of the patient. So going on with the history, the patient is able to talk and he gives the history by himself. An examination, he appears sick with a heart rate of 220 per minute, which is irregular, the BP of 110 over 160 millimeters of mercury, and a respiratory rate of 24 with a saturation of 90% on room air. Systemic examination is unremarkable. There is no evidence of any organ system involvement. The questions now that you need to answer is how do you approach this patient? What is the most important initial investigation that you do? And how do you manage this patient? Let's try to answer these questions one by one. First, for any medical patient, you need to follow certain steps to come up to a diagnosis. First, you collect the chief complaints. Based on the chief complaints, you do a primary survey, and primary survey or primary assessment should be followed by stabilization. You take a focused sample history with the relevant negative points. You will not be taking elaborate history in the emergency department. You conduct a general physical examination. Then, based on your findings of history and the general physical examination, you decide which system is involved. You examine that system thoroughly, and then you move on to examine the rest of the systems for the effects other to find a cause in other systems. And then you come to a provisional diagnosis. You do some bedside investigations to support your provisional diagnosis. You can do some imaging studies and you come to a final diagnosis after your reports are out. Once final diagnosis is out, you will dispose the patient appropriately. So these are the basic steps in evaluation of any patient. Coming back to the current patient, you need to do a primary assessment. Always follow ABC approach. It's CAB approach when the patient is unconscious and if the patient is conscious, you follow ABC approach. So in this current patient, the patient is able to talk in full sentences, which means his airway is patent and his breathing is adequate. Oxygen saturation is on the lower side with 90% on room air. We start with oxygen with nasal pharynx or face mask because hypoxia could induce ischemic symptoms which has the patient is presenting with. Your target saturation is always 92 to 94% without any respiratory distress. Respiratory rate in this current patient is 24 per minute, but there is no evidence of any other respiratory distress as per the scenario given. So Because your airway and breathing are normal, you go on to assess the circulation. But if you find any problem with airway or breathing, first you will try to manage the airway and breathing, stabilize, and then move on to the next step. That is, if there is a problem with the airway, you manage the airway first. Once you are satisfied that airway is been appropriately managed and the patient is able to maintain his airway, you move on to breathing. You support the breathing with oxygen, whatever means needed. If intubation is needed, mechanical ventilation is needed, you get on with that, and then you proceed to check the circulation. When you are checking the circulation in this particular patient, there is tachycardia with a heart rate of more than 150 per minute, and the pulse is irregular. So the patient should be connected to a multi-channel monitor. When you connect the patient to the multi-channel monitor, this is the rhythm you are getting. The heart rate is over 200, 223 exactly. And you know the steps in assessing the rhythm. In my earlier video, I have told you how to assess a rhythm. Yes, you need to check for those 5 points. Rate first, the rate is given. Next comes the rhythm. Rhythm is irregularly irregular. Then check for presence or absence of P wave. There is no P wave anywhere. Yes. Once P wave is not there, no question of PR interval. You proceed to QRS duration. QRS duration appears narrow. So it's a narrow irregular tachycardia. So the same thing I have presented here. The rhythm is irregular rhythm. There are no P waves. Rate is 223 per minute, which is tachyarrhythmia. QRS is narrow. So the impression is a narrow complex irregular tachycardia. Narrow complex irregular tachycardia is almost always an atrial fibrillation, and unless otherwise proved. You know that atrial fibrillation can be with normal ventricular response, or it can be with a fast ventricular response. Because the rate is high, there is a number of QRS you have counted to calculate the rate. This is the ventricular rate that you are calculating. Because POs are not there, you cannot calculate the atrial rate. So the final diagnosis, it could be an atrial fibrillation with fast ventricular response. Patient's BP has been given in the scenario. It's 110 by 60 millimeters of mercury. His GCS is 15 by 15 as he is talking in full sentences. Now we have a patient with atrial fibrillation with fast ventricular response. This may lead to life-threatening problems if life-threatening problems are already not there as like in this case. Now you need to prioritize your management. What are you going to do next? So before going into exactly prioritizing and managing this patient, let's talk what happens when the patient is having tachycardia or a tachyarrhythmia. The given scenario, one has to look for signs of instability. So what are the signs of instability? Yes, signs of instability means the signs that tell you that the patient is having a compromised circulation because of deranged heart rate. As you all know, cardiac output is heart rate into stroke volume. When the heart rate is too high, yes, if you remember your cardiac cycle correctly, is the diastolic phase which gets reduced as the heart rate increases. As the heart rate decreases, diastolic phase gets prolonged. As the diastolic phase is getting reduced, there will not be enough ventricular filling, and there is a loss of atrial kick also, which gives about 15% of blood to the ventricles. That leads to reduced stroke volume. Reduced stroke volume leads to reduced perfusion to all the vital organs. This is the problem with tachycardia. So signs of instability, what are the end organ damage signs that you get when the patient is unstable due to an arrhythmia? Acutely altered mental status, there is a reduced blood supply to the brain, mental status can be altered. Ischemic chest discomfort, the patient similarly having reduced blood supply to the heart and the heart is functioning more vigorously, high heart rate, there is high demand for oxygen. When there is reduced demand, the cardiac muscle can experience ischemia. Acute heart failure, Because of this increased demand and reduced supply, demand supply imbalance, heart can give way, it can suddenly stop, giving rise to acute heart failure. There is left ventricular failure. Signs of shock: as perfusion decreases, there will be signs of shock, and hypotension is a late feature. If any one of these five signs are present, the patient is said to be unstable. So immediately what you need to do? The current patient has a vague chest pain, which is a sign of instability, which is an ischemic cardiac chest pain. Hence, immediate treatment before a final diagnosis takes precedence. You won't wait for diagnosis to treat the patient. Whatever is the cause of AF in this patient, because there is AF with fast ventricular response, you need to reduce the ventricular rate, rate control drugs you need to give, and stabilize the patient. In some cases, loss of atrial kick can lead to diminished cardiac output with hypotension and congestive heart failure. Emergent rhythm conversion can be done in these patients if there is already patient is in shock. Sample history. History and physical examination are needed to find out the cause of AF. Ask for patient's current symptoms and let him or her explain. Any specific positive or negative points you need to know, you can ask leading questions. Otherwise, the patient should explain the history. Usual symptoms of tachycardia are due to either awareness of one's own heartbeat or the hemodynamic effects of the heart rate. Patient will usually describe an uncomfortable awareness of heart rate, a racing heart or pounding in the chest, even at rest. You all would have experienced when you work vigorously, the same feeling, awareness of heartbeat, which is uncomfortable. Hemodynamic effects include lightheadedness, giddiness, chest pain, fainting, syncope, altered sensorium, and breathlessness. All are due to reduced supply to the vital organs. History should also include points with proper evaluation of each symptom. Make special note on allergies. Medication history and past medical history will give a clue to your cause for AF, and it is very very important in elderly patients. Timing, quantity, and type of last meal is important when you need to manage the airway and an intubation is planned. Events preceding and following should also be recorded carefully, especially intake of any new medicines, physical activity, and any previous hospital visits, which can give you a clue regarding the cause of atrial fibrillation. Next, you need to do a general physical examination, which may reveal an irregular pulse with normal or high heart rates, which can be of low volume. Pedal edema and raised JVP can be present in patients in pre-existing CCF who develop AF. Cyanosis can be present in hypoxic patients. Hypotension and signs of shock are usually late features with AF. Raised temperature is a feature of endocarditis or sepsis, which leads to AF. Coming to systemic examination, yes, you need to examine the cardiovascular system first. Clinical manifestations and signs depend on the cause of the atrial fibrillation. You can see an enlarged cardiac celerity when there is cardiomyopathy, displaced apex beat, cardiac murmurs in case of valvular heart disease, altered heart sounds can be noted, cardiomyopathies and valvular heart diseases. Pulmonary symptoms can be noted in heart failure and thromboembolism. Altered sensorium can occur due to cerebral hypoperfusion. ECG features of atrial fibrillation include absence of a discernible PVS with flat or chaotic isolated baseline. QRS complexes are narrow unless there is a pre-existing bundle branch block, which can widen the QRS complex, or a pre-excitation syndrome, which can again widen the QRS complex. There is a irregular ventricular rhythm. Heart rate can be normal or high. Atrial rates are in excess of 600. Usually, ventricular rate is around 120 to 170 due to the atrioventricular node refractory period, which allows only certain beats to be transmitted to the ventricles. So, what are the causes of AF? Let's go system wise. Most common site as cause of atrial fibrillation include the cardiac system. Disorders like prolonged hypertension, especially when it is not controlled adequately, or the drugs that used for controlling hypertension can lead to AF. coronary diseases, cardiomyopathies, valvular heart disease, rheumatic heart disease, congenital heart disease, myocarditis, pericarditis, anything can cause AF. Pulmonary system, mainly pulmonary embolism, COPD. COPD AF is common, but a most common rhythm which you see in COPD is multifocal atrial tachycardia. In patients with obstructive sleep apnea also, most commonly you see MAT, but AF can also be seen. Systemic disorders like hyperthyroidism, metabolic syndrome, obesity, inflammation and sepsis. Postoperative after cardiac surgery, binge alcohol drinking, which is called holiday heart syndrome, can develop AF. Lone AF is a variety of atrial fibrillation wherein there is no pre-existing disease. AF occurs by itself. It occurs approximately in 10% of patients. Thus 90% have a discernible cause. Coming to the pathophysiology of AF, how it occurs, there are triggers for AF: an abnormal atrial myocardium with multiple reentrant circuits or automatic foci which surpass the SA node. There is rapid electrical activity in the atria with disorganized and ineffective atrial contractions. These disorganized and ineffective atrial contractions can lead to loss of atrial kick, which reduces the ventricular filling by 15%. The conduction through the AV node and the disorganized and rapid ventricular response can occur if the atrial refractory period is overridden. And finally, the induction to hypotension and cardiogenic shock. So, AF can be conveniently divided into different classes based on the duration and how long it is stayed. First of all, paroxysmal atrial fibrillation, which is atrial fibrillation lasting for less than 7 days. It usually terminates spontaneously without any treatment, or with treatment, it can terminate earlier. Persistent AF, which lasts for more than 7 days, it doesn't terminate by itself but requires treatment to terminate. Long-standing persistent AF, lasting for more than a year. Permanent AF, when a decision has been made not to terminate AF, especially in valvular heart diseases. New or recent onset AF is symptomatic patients presenting to ED without any prior history of atrial fibrillation. Main complications of atrial fibrillation include thromboembolic complication rather than cardiogenic shock. Due to fast rate and stagnation of the blood, there is venous and arterial thrombus can be formed. Thrombus can be potential for systemic and pulmonary embolization. Conversion from atrial fibrillation to sinus rhythm can propel a portion of the thrombus out into the systemic circulation, which can lead to stroke, which is very, very common in patients with AF. Risk increases with the duration of AF. The AF is long-standing. Along with the duration of AF, risk of thromboembolic complications also increase. So let's look into risk of thrombus in relation to duration of AF. The AF is for less than 12 hours, the risk is very, very less at about 0.3%. If the AF is lasting for 12 to 48 hours, it's about 1%. Patients with heart failure and diabetes with less than 48 hours of AF, they have high incidence of thromboembolic complications, 9.8%. Patients who are aged less than 60 years without any comorbidities and AF is lasting for less than 48 hours, they will have 0.2% risk of thromboembolic complications. The AS is lasting for 48 hours, it's called high risk patients. So there are two types of scoring systems, CHARTS 2 and CHA-DS2 VAS score to determine the risk of thrombosis. In CHARTS 2 score, each of CHF, hypertension, age greater than 75 years, diabetes carry 1 point, stroke or TIA carries 2 points. In CHA2-DS2 VAS score, CHF or LVF with ejection fraction less than 40% carries 1 point, hypertension carries 1 point, age greater than or equal to 75 years carries 2 points, diabetes carries 1 point, stroke or TIA or thromboembolism earlier carries 2 points. Any Vascular disease, peripheral vascular disease carries 1 point. Age between 65 and 74 years carries 1 point. And if female patient, it carries 1 point. Patients can be divided into low risk and high risk based on charts 2 and CHA2 DS2 VAS score. Low risk patients are those with charts 2 score of 0 or CHA2 DS2 VAS score of 0 or 1. High risk patients will have chart score of greater than 1 or a charts 2 DS2 VAS score of greater than or equal to 2. So how are you going to manage a new onset atrial fibrillation? Yeah, you're right. New onset atrial fibrillation is an atrial fibrillation which has started less than 48 hours with symptomatic presenting to ED. Duration less than 48 hours. There is low risk for thromboembolism by CHA2 DS2 VAS score or charts 2 score. Treatment is chemical or electrical cardioversion to sinus rhythm. If no successful conversion, if there is successful conversion, no antithrombotic therapy is needed. Duration less than 48 hours, low risk for embolism. Ventricular rate control is the treatment of choice. You target a heart rate of 100 beats per minute. No antithrombotic therapy is needed, but the patient should be followed up very closely. Duration greater than 48 hours. Ventricular rate control less than 100 beats per minute is the target. Therapeutic anticoagulation has to be given for 3 to 4 weeks. High risk for embolic complications, ventricular rate control less than 100 beats per minute. Therapeutic anticoagulation for 3 to 4 weeks should be the target. Algorithm for management of AF, atrial fibrillation with fast ventricular response. The patient is stable, you go with rate control. The patient is unstable, you can go with cardioversion depending on your charts to CHA2 DS2 VAS scores. You can either treat the AF or the underlying cause. The patient is stable, that is, he is maintaining BP and there are no signs of instability, you go for rate control. If there is chronic AF, treat the underlying cause, not the AF. Start risk-based anticoagulation. Consider rhythm control if not tolerated. First time AF, that is less than 48 hours duration. Evaluate and treat the underlying cause. Early conversion, risk-based anticoagulation therapy. First time AF greater than 48 hours. Start Coumadin and convert in 3 weeks to versus TE plus heparin, then 4 weeks of Coumadin, rate control and anticoagulant if rhythm is not tolerated. Permanent AF less than 48 hours, paroxysmal AF less than 48 hours, early cardioversion observation, risk-based anticoagulation, rate control or antiarrhythmic if patient is unable to tolerate symptoms. Paroxysmal AF greater than 48 hours, risk-based long-term anticoagulation, conversion requires anticoagulation, 3 weeks of Coumadin versus TE or heparin if Coumadin for 4 weeks, convert if AF is poorly tolerated. So what are the drugs that you use for controlling atrial fibrillation? Mainly the calcium channel blockers like verapamil and diltiazem. They slow the AV node signal conduction by blocking the calcium channels. They are very effective in controlling the lead. Diltiazem carries the lowest risk of hypotension because it has a less negative inotropic effect. So if the patient is in hypotension and you decided not to cardiovert the patient, you can go with diltiazem. The next option include beta blockers, especially metoprolol. You can use propranolol, esmolol, atenolol also. They slow the AV conduction by decreasing the sympathetic tone. They are also very effective in rate control, more negative inotropic effect than diltiazem and carry greater risk for hypertension, particularly in patients with borderline low blood pressure or poor LV function. Digoxin, no more used. Slow AV conduction by increasing the parasympathetic tone via the vagus nerve. Limited role in the ED because of its slow onset of action, long half-life, and ineffectiveness at rate control in typical high sympathetic tone ED patients. Has a role in rate control in sedentary patients or those with chronic CHF. Amiodarone or dronedarone, Antiarrhythmics that have some beta blocking activity, less effective than pure rate control agents listed above. If cardioversion is the goal, these drugs may be single agent approach to maintaining normal sinus rhythm and rate control in atrial fibrillation. You have an option of cardioversion, but cardioversion is usually not performed for AF unless you clearly know that the AF has started in less than 48 hours and the patient has no clot in the right atrium. Then only you go for cardioversion. Patient need anticoagulation before going for cardioversion. DC cardioversion is the preferred method. Preparation, IV, connect oxygen, cardiac and pulse oximeters. Following standard procedures, sedation protocols, advanced cardiac life support, airway material ready and available. You go for synchronized DC cardioversion at 100 to 360 joules, depending on whether you are using a biphasic or monophasic defibrillator. AF less than 24 hours, start with 100 joules. Biphasic conversion offers a better success rate and fewer complications and achieves conversion of 50% than the monophasic levels. Success rate of DC cardioversion is 75 to 93%. Complications, 15% of complications including bradycardia, ventricular tachycardia, ventricular stunning leading to hypotension can happen. Anticoagulation approaches. Pre-cardioversion anticoagulation, usually done with warfarin for 3 to 4 weeks before you cardiovert the patient. TTE plus heparin or enoxaparin can be used. If no clot and transesophageal echo, administer heparin and enoxaparin and proceed with immediate cardioversion. Post-cardioversion, warfarin for 3 to 4 weeks has to be continued. If you have used TE with heparin or enoxaparin, also warfarin has to be continued for 3 to 4 weeks. Advantages withstood the test of time. Conventional warfarin, whereas heparin or enoxaparin shortens the period of anticoagulation, reducing the risk of bleeding complications, also reduce the time in AF, increasing the chance of successful conversion into sinus rhythm. Disadvantages of conventional warfarin include prolonged period of anticoagulation, delays cardioversion, has no definite guidelines, requires highly trained physician and expensive equipment to perform TE. So that is an approach to the AF. Coming back to the current patient in the scenario, the patient has history of 2 weeks. It's definitely more than 48 hours and he is gradually worsening. Chance of thromboembolic complications are high because patient is a known case of hypertension and diabetes. The patient is unstable and he is having ischemic chest discomfort. Hence, the patient should get rate control along with anticoagulation. Thank you. If you have any doubts on this video or if you want to suggest any corrections, please feel free to inbox me. And if you want any special topics as a lectures, for that also you can inbox me. For these videos to be delivered directly to your inbox whenever I post a video, please subscribe my channel. Thank you.